function smoothly. So these are lovely pain which helps us to give a better care towards patients. It's the first government pediatric hospital in India to have established pain services along with palliative care services. Acute pain services are available 24/7. We have a resident or a fellow who is present around the clock to assist and manage the care. Chronic pain services, both inpatient and outpatient, is available from the year of 2021, attending around 25 patients. Palliative care services have also been started from the year of 2022. So next, I would like to call upon stage Dr. Chandrakala ma'am to introduce our guest, Dr. Stephen Fredericksdorf sir.
Good afternoon, everyone. So, warm welcome to our event. So, I am delighted to introduce our guest speaker who warmly accepted to give speech on the pain and palliative care for our event. He is an accomplished individual in the field of pediatric pain medicine and palliative care and integrative medicine. He is a professor of pediatrics and chief pediatric pain, palliative and integrative medicine, medical director of the START Center for the Pediatric Pain, Palliative and again the integrative medicine. And he received the prestigious Child Kind International Pain Relief Certification and Joint Commission Palliative Care Certification. In 2024, recognized as a leader by the Time magazine in 100 most influential people in the health edition. Received Elizabeth Narcissian Award for the outstanding educational achievements in the field of pain by American Pain Society and Hastings Center Cunning's Dixon Physician Award also. Was an editor of the Journal of Pain and Symptom Management from 2013 to 20. Principal investigator of National Institute of Health and National Institute of Cancer. So in 2008, he founded, and since he is directing the pediatric pain master classes for a week long, which is an intensive course for disciplinary professionals. And he has presented more than 850 lectures about pediatric pain medicine and palliative care over 30 countries. He has a track record of research and publications, including 75 peer-reviewed articles and some contribution to the more than 25 books. He is the immediate past president of the Special Interest Group on the Pain in Childhood of the International Association for the Study of Pain. He received his MD degree from the Medical University of Lübeck, Germany, completed his 5 years of pediatric residency in Witten, that is Germany, and fellowship in pediatric pain in the University of Sydney, that is Australia. This is about that.
Thank you, Chandrakala ma'am. So now I'll be playing a short video by recorded video of Stephen sir. Sir is going to join us, but we hope next time we'll be able to have him questions.
Hello, lovely people. My name is Stefan Christoph, and I am the Elisa Markstein Professor of Pediatric Pain Medicine, Palliative Care, and Integrative Medicine. Hello, lovely people. My name is Stefan Christoph, and I am the Elisa Markstein Professor of Pediatric Pain Medicine, Palliative Care, and Integrative Medicine here at the UCSF Palliative Children's Hospitals in San Francisco, Oakland, in California. And thank you very much for inviting me to talk about does pediatric pain matter? And as you can see, these are just pictures here from Oakland and San Francisco. So many of you have the ability to come to the Bay Area and see the beauty of this area and to meet us. So congratulations to IGICH for having this Pediatric Pain and Palliative Care Awareness Week, and thank you for inviting me. This is very exciting. I put a handout in, so this is, if you use this QR code, you can just use your phone and then click on this and the slides, and some additional information is right in there. So, does pain matter? Well, a few years ago, I was invited to kindly speak in Denmark, in Copenhagen, and they showed this little video. And so this is a 5-year-old boy who comes to the emergency room, and he is going to need stitches. And even if you do not understand Danish, there may be one or two of you who don't, if you look at Marius, just can you tell me afterwards what went wrong? Because it started out really, really well, and then something is going wrong.
Så slår din finger, så du ham op her. Han har fået revet det yderste stykke af fingeren af, og det hænger meget løst. Men hvad er der sket? Nu pakker jeg den op forsigtigt her. Så kommer Michael og kommer til skadefingeren og pakker fingeren ud af forbindingen. Kan jeg se, at det er det vi gør, når vi skal bedøve fingeren, så at det ikke kommer til at gøre ondt, når vi skal rense og sy. Så en 5-årig dreng kan godt være rigtig stærk, så det er så lidt for stærkt, så han kan holde fast med og bedøve fingeren, og vi ikke nogen flere kollegaer, og så er det 5 voksne mennesker, der er så godt en lille arm, for at vi kan få
So, should we quickly count how many adults are holding down this 5-year-old child for an elective procedure? We're not saving lives here. This is terrible. This is really bad medicine, yet it's happening in most children's hospitals around the world. And this has to stop. We were trained this way, and now we know this is a terrible mistake. We often hear, well, you know, Dr. Friedrichs, we just do not have enough staff for pediatric pain control. It's interesting that we always have enough staff to hold down children. So, in the Declaration of Montreal 2010, access to pain medicine is a fundamental human right, and it's a human right violation not to treat. But to quote Oscar Wilde, I don't mind pain as long as it doesn't hurt. But here lies the problem, it does hurt. So why has pain been so ignored? So I was born in 1968, and there was a textbook written, and something spectacularly wrong was written. Something like, pediatric patients seldom need medications for the relief of pain. They tolerate discomfort well, and rarely has anyone like Dr. Smolfatier been more wrong in that particular instance. So how well are we now, 50 plus years later, in preventing and treating pain in children in healthcare facilities here in the United States and worldwide? So about 10 years ago, I asked the staff of my own children's hospital, and we just want to know, on a scale of 0 to 10, how good are we as nurses, as doctors, as social workers in preventing and treating pain in children? And the results were very encouraging. Our staff rated themselves as 9 out of 10 in awesomeness in doing pretty much everything to prevent and treat pain. So that was good news. So I was thinking, as the director of the pain service, I can retire. However, we actually then asked the children and their parents, and that level of enthusiasm was absolutely not shared by the patients at all. They told us we were terrible. And the number one thing, the worst pain happening in one of the most advanced children's hospitals in the United States were needle pokes, blood draws, vaccination, IV cannulations, even more than cancer pain, trauma pain, surgery, or all that. So clearly, we had to do better. And we look, all data is showing us that pain in children's hospitals and children's clinics is common. is under-recognized and is under-treated. And what's happening in terms of treatment very much changes like from one institution to the other without any rhyme or reason. And in your slides, not more data about that both in North America and Canada and the United States, but also many other countries, we find that a large number of children have unrelieved pain, both acute and chronic. And when parents come to us with their children, when they trust their children to us, to our care, they expect that the pain of the kid is relieved. They assume that in 2024, everything possible is done to relieve pain. And those of you who have worked more than, let's say, like 10 minutes in your hospital know nothing is further from the truth. It's much more often about how it's convenient for us and not what the right thing is to do for children. And there's nothing worse for a parent to see a child being in pain. And in fact, there's nothing worse for a child to be in pain. And if you actually ask a parent, why are you coming here? They take pain control as the second highest priority after get the right diagnosis. And that's the number one priority of the child. So does pain matter? Well, we are talking about the number one priority of pediatric patients. We're talking about the number two priority of parents. So that's pretty high up on the list. And of course, parents have many concerns and they hold misconceptions because they don't know. They are then wrongly told us, oh, this is just anxiety, or oh, this is not going to be as bad, oh, they're not going to remember. So we basically lie to them and in order to make it better for us. So parents lack the information and we have to give them the right information. We know that compared to adults, adults get 2 to 3 times as many pain medications as children for the same underlying condition. And the younger a child is, the less likely it is to get appropriate pain control. In other words, a 27-year-old adult after chest tube is going to get better pain control than a 17-year-old teenager who's going to get better pain control than a 17-month toddler who's going to get better pain control than a 17-day-old baby for the same painful procedure, a chest tube. So why bother? I mean, that little bit of holding down, this happened to us, right? So if we turned out well, so why bother? Well, the problem is that children who experience persistent pain turn out to become adults with a much higher risk of developing chronic pain, more anxiety, and more depression. We will know, I'll show you a few slides, that on the neonatal intensive care units, that unrelieved pain increases morbidity and mortality. Babies are dying more likely because of unrelieved pain. And even when babies that survive the infancy from neonatal intensive care units, they actually remember this much later. So when they have blood draws or vaccinations at age 10, 11, 12, they actually have much higher pain ratings than their peers and children who were not on neonatal intensive care units. And of course, get this, 1 out of 4 adults is afraid of needles. And that leads to avoidance of healthcare. They may not get vaccinated. They may not seek out medical care and have like non-adherence with that. And we often hear, oh, it's just a baby. Babies don't remember pain. Well, that's really interesting because they do. Boys who have been circumcised, and mind you, cutting off a piece of your penis is probably pretty painful. There was a study showing that boys who have been circumcised with appropriate pain control, so in 2024, that would mean a penile block and EMA cream or lidocaine cream, compared to boys who've been circumcised without pain control. The boys who've been circumcised without pain control scream much longer and much harder 4 to 6 months later. So they do remember that's just one painful procedure. And many of our infants have experienced 100, 200, 300, more than 480 painful procedures during their stay on the neonatal intensive care unit. And this has without adequate treatment, has negative long-term consequences. It increases morbidity, hypoxia, coagulopathy, respiratory incoordination, increased intracranial pressure. And that causes a higher risk of brain bleeds, interventricular hemorrhages, and that has a high risk of mortality. So And infants who had prior surgery have need actually more pain medication and have lower pain threshold later on in life. Yet, today, in 8 out of 10 cases, babies on the neonatal intensive care units, when we undertake painful procedures such as blood draw, such as blood gas or something like this, they are performed without any type of analgesia. That is unethical. That's really, really bad medicine, and we need to become so much better because this is serious short and long-term consequences. Every single painful event causes immediate physiological and behavioral instability. And there's a significant relationship between physiological markers of neonatal pain and oxidative stress. And we even know that if we have repeated procedural pain in preterm infants, that those children actually grow up with a smaller head, even after accounting for multiple medical confounders. So the brain growth is inhibited. And how children remember has a great influence on pain experience during subsequent procedures. In other words, Marius, we remember when he was held down, so if something unethical, something bad medicine happened when they come the first time to hospital, they remember the next time they come back that we need more man or woman power, they need more analgesia or anesthesia for the same pain control. So all those children who are screaming when they come into our hospital, it's because of us, because we failed them, because we made a poor decision that we just need to sort of get through our busy day and we just sort of hold them down unless doing the right thing for every child and every time. And even if we do that right the second or the third time for Marius, he will need more analgesia in subsequent procedures. So we also know that that the surgery during infancy has local and global consequences on sensory processing observed 9 to 12 years later. And as I already showed you in another study, kids have a thinner cortex and cognitive impairment for that reason. And they have extremists who had lots of recurrent neonatal pain. That's a risk factor for impaired school-age neurocognitive outcome for that matter. And that actually persists into early adulthood. So that's bad news. We need to do much, much better for that. We know that children with trauma, this is infants as young as 1 year, toddlers and school-age children with a burn or a car accident, that the more morphine they get right after the trauma, the less likely it is that they do develop post-traumatic stress disorder. So good pain control reduces the risk of post-traumatic stress disorder for the matter. So coming back to the original question, does it matter? Yeah. Does analgesia improve the outcome? Yes, it does. It has been proven over and over in our clinical experience and of course in animal models, as you can see over here. So has there ever been a legal consequence? We now know it's unethical and bad medicine to hold down children and just sort of do something painful. So has there ever been a legal consequence of not doing the right thing? So I'm now in California, but before that for 15 years I was in the great state of Minnesota here in the United States. And in 2006 there was the famous case of a 9-year-old by the name of Jess. And she had an accident with a boat propeller, lots of lakes in Minnesota. And Dr. Carl Seaman from a city up north in Bemidji, Minnesota, nicely said Jess's fractured leg and sutured her wound. However, he failed to give any pain medication after anesthesia. So can you imagine, Jess woke up and did not get appropriate pain medication in 2006 after the surgery. So obviously his medical license was suspended in 2007 on the ground that he had refused to embrace the latest methods to control pain. And Dr. John King, who was the executive director of the board at the time, said the minimal standard of practice is that you do something about pain. Doing nothing is not an option. So Jess is actually doing well. I brought a photo so you can actually look at her. So, did I mention Jess is the golden retriever and is the Minnesota Board of Veterinary Medicine? As a vet in the United States, you use your license if you do not provide adequate analgesia. That's mandatory training, and most veterinarians have 5 to 10 times more paid training than physicians. And many states, such here as in Oregon, basically have that minimum pain management is now mandated by rule before you can operate a hamster or cat, and may not be omitted by the doctor or declined by the client. All right, so finishing up, how do we then manage acute pain and chronic pain in children? We, in 2024, must, as they have to, as there's no other bloody way, provide pediatric multimodal analgesia. So we provide basic analgesia such as paracetamol and ibuprofen. We think about opioids, weak opioids such as tramadol, or strong opioids such as morphine. And we give them around the clock, and so it's scheduled. And of course, opioids are associated with many side effects, and they're potentially lethal. If you give too much morphine and otherwise healthy child, they may stop breathing. However, if there's no other analgesic equal in potency and effect, which has been discovered or developed to reduce MS suffering, and opioids need to provide adequate treatment of pain and suffering after surgeries, burns, physical trauma, and medical illness, such as sickle cell crisis, cancer, and pancreatitis. And then, on top of this, of course, we need to offer integrated non-pharmacological modalities, distraction, mind-body techniques, hypnosis, breathing, progressive muscle relaxation, acupuncture, acupressure, aromatherapy, massage. All of this significantly decreases the pain perception. We need rehabilitation, physical therapy, exercise, getting kids out of bed, for that matter. We need psychology, family support, and to give cognitive behavioral therapy. Social work helps with psychoeducation, supportive counseling, spirituality, child life, chaplain. All of this helps to provide the best pain control. Pediatric anesthesiologists provide neonatal infusions, peripheral block, plexus nerve blocks, neurotic blocks. Yeah. All of this really can help significantly provide better pain control with far less side effects. We use adjuvant analgesia, gabapentin or pregabalin, alpha agonists such as clonidine or dextromethorphan, Precedex, NMDA antagonists such as low-dose ketamine or methadone for that matter, sodium channel blocker, topical lidocaine, IV lidocaine, with of a special very low-dose tricyclic antidepressants such as amitriptyline, nortriptyline. Maybe we think about an antihistamine, antimuscarinic such as hydroxyzine. Sometimes that was test tubes. We think of the muscle relaxant such as cyclobenzaprine. So all those things help us in addition to all the other modalities in the right case. And thinking back of Marius, what do we do for every child, every time, everywhere, when we put a needle into them? Vaccinations, blood draws, IV cannulation. And of course, we always offer lidocaine cream, Amla or Focus lidocaine cream, for that matter, for every child, every time. We start holding our children. We do comfort positioning, and we have much more information in my handout how we roll this out system-wide in many hospitals now. Call this the comfort promise. Age-appropriate distraction, and for babies younger than 12 months, sugar water or breastfeeding, for that matter. And if all of this is not working because we failed those children in the past by holding them down and they're completely flipping out and freaking out, all these are children with, who are neurodivergent on the autism spectrum disorder, then we will consider sedation. And number one, of course, would be analgesics. So I have 3 children. This is I took them to the doctors a few years ago, and you see they're exactly what I would be doing. I put the lidocaine cream on at home. You can buy this over the counter. My daughter's sitting on her lap, so we're not holding her down. She's playing a little game on a tablet, and this is her vaccination.
Is that Orion? What did I need to do?
Well, practice with the line.
I didn't feel it.
You didn't feel it?
Ow.
Excellent.
I don't know why.
all my 3 children getting vaccinated with NMTs and they didn't feel it. Right. So you remember Marius? How about a plan B? So how do we do this so much better? So this is my best friend's son when he was playing with my kids, and he was like, they were running around, and he unfortunately ran straight into metal pole, had a huge laceration on his forehead. So he was bleeding. I had to put him into my minivan. I put my 3 kids in. We drove to the local emergency room. And like most state-of-the-art emergency rooms, the Children's Minnesota has a policy when kids are coming in and the nurse thinks that stitches are in order, that you apply numbing cream. And for open wounds, it's lead cream, and something the pharmacy can easily mix, which is lidocaine, epinephrine, and tactocane for an open wound. So this was on for half an hour. And then he actually needed 12 stitches. And all I saw during those 12 stitches was the following. So he's sitting upright. He had the option to sit on his parents' laps. He has decided to do this on his own. Let's say he's distracted. And we note the skill. Why on earth would we hold down children for painful needle procedures if we can have this 96% of the time? In addition to this, we of course are thinking about chronic pain, so the headaches, the migraines, the functional abdominal pain, the lower back pain, the widespread musculoskeletal pain. Well, basically, this is about physical therapy, exercise, using psychology, using non-medicine strategies such as integrative medicine, and normalizing life. First, they go back to school, then the pain gets better. First, they normalize the sleep, then the pain gets better. First, they normalize their social life, then things get better. And this is a situation where opioids are contraindicated. We're not prescribing morphine or other strong pain medications for chronic pain. And most medications are really not necessary, and it's really about a rehabilitative, integrated approach for that matter. All right, so coming back to the original question, does pediatric pain matter?
Yes, 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 yes. Yes, 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 yes. Yes, 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 yes.
I think you get the gist. The answer is yes. Failure to implement evidence-based pain prevention and treatment for children in medical facilities is now considered inadmissible and poor standard care. If you're interested more in this stuff, I'm a co-director of the Pediatric Pain Masterclass, an annual course about pediatric pain medicine here in San Francisco. So we have some information about that course in your handout. And the next time it's happening is on December 7 to 13, 2024, here in San Francisco. With that, thank you very much for your attention. There's my email address if you have any questions or comments on this matter. I put additional articles in my handout, so you're welcome to have a look at them. And I wish you an amazing rest of the day in this really, really important pediatric pain and palliative care prevention day at the institution. And all the best to you in India. Bye-bye.
Thank you, sir, for such a wonderful talk. So now Sarah will be taking over the rest of the program. I would like to call upon Dr. Bhagya Devi, Assistant Professor, Department of Pediatric Anesthesia, to introduce Ms. Anya Devi.
Good afternoon, everyone. When we first were thinking about making a small program on pain and palliative care, we did think about psychotherapy, and at the same time, this topic of play therapy came into our minds. When we always look up into child playing, our perceptions from childhood is we go to school from 9 to 4, we come back, and we want to relieve our stress from a serious learning. That's what we always thought. But actually, when you keenly look through a child playing, it is a serious learning by all itself. I always believe when children is playing, they use the toys as their words, and the playing itself is a form of language. They're trying to communicate to us, talk to us, they see things through playing. Like one of the famous, well-known clinical psychologists, Virginia Axman, I always believe what she said. One of her quotes is, enter into a child who's playing. That is the place where you find a nice amalgamation of your heart, mind, and soul. So I'm really thankful for Anya for being here. So to introduce Anya, she is a certified synergistic play therapist and also a parent coach therapist. And to introduce her, once finishing from diploma on computer applications from Loyola, she has entered into various certified courses. She has finished certifications in various therapies like personal coaching, art-based therapies, neurodramatic plays, therapeutic play skills, and also some of the few not so well-known fields like the serious trauma issues, even the adolescent and children traumatic issues that are dealt with. We're really happy having you here, Anya. Kindly take over. I think you're okay. Just give us a minute.
We were actually looking for about play therapy, and we Googled and we were trying to look for play therapists in Bangalore. And that's when we started in Anya. It's so lovely to have her here, and she's actually sent me a 1 minute video clip on how she her play therapy room. I hope you have it in your presentation. That's lovely. Anya. Just, just trying to pull up the slides. Just give us a minute. I'm so sorry.
So, while we waiting for slides to come up, I was just curious, what is your perception of play therapy? What have you seen? What have you heard? What do you think happens in play therapy room? Anyone? Have you maybe read something, seen a video?
Actually, we had a kid of autistic kid in my house, and their parents used to take him to play therapy. And when I asked them what exactly that was being done, they told us that it was more so to do with sand, and where he's given various toys, and the therapist actually observes. So we did a lot of sessions.
Okay. So when I was preparing for this talk today, I fished out every single possible report, article, study on the use of play in alleviating children's pain. And there's a lot of misconceptions in terms of play therapy in this regard. Reports have misrepresented it in terms of distraction play, you know. For example, what we saw in the video where the child was playing with a video game while he was getting his shots, that is distraction play. Then there is normal play, which is considered free play, which is where a child is given some toys and they're not told what to play with, how to play, what to say, no questions. There's just a child with toys, and it's completely child-led with no agenda, nothing of the sort. And then we have play therapy. So today I just want to talk about, and I'm going to take you through a case as well, where I'm going to show you pictures of what happened during this child's experience of pediatric pain and how she recreated it in a play therapy session.
We are having, I think, the Mac and the Android issue, I guess. Uh, you know what? I mean, just give us a minute because okay. It's just trying to open. Let's. Is it okay, Anya, if we can have Dr. Shravanti do her presentation? I hope that's okay, Shravanti. No, I know we are waiting, but this is taking some time, and I don't want to keep you guys waiting. That's my only worry. I forward to. And I'm so sorry. This is yeah. Yeah, I think that. No, I think we are having some taking some time trying to connect with that. This Apple and Android issue is always a thing that's so tricky. I'm so sorry. And it says it's exceeding the capacity also, I guess. So and it's a different key file. Yeah. Oh, I'm so sorry, Anya. I'm just kind of.
I can convert it to Microsoft.
Apple laptop. Apple laptop. And government will connect Apple to this. Laptop, I'll check to this. No, but download anyway. It's a keynote. That's keynote. That's what I'm saying. It's keynote. I'm telling you, the export has to be different. That's always an issue. No, worry. I don't have the app. You know what? Why don't we just display the on your computer itself? That will be hello. Or if it no, it says they don't have Android version, right? This is taking time. You go ahead. And we will sort this out. We'll let Dr. Shanti finish her talk. Is that okay? No, we could have figured this out yesterday. So I just help with Dr. Shanti.
We regret the inconveniences. I would like to call upon Dr. Shruti to introduce Dr. Shravanti.
Good afternoon, everyone. A warm welcome to all. I would be introducing Dr. Lakshmi Shravanti. Ma'am has done her MD in psychiatry and her DM in child and adolescent psychiatry. And she's even done a PG diploma course in music therapy. And she's affiliated with IMANS. And her areas of interest are epigenetics, attachment and trauma, and mood and anxiety disorders, as well as parenting, and she is deputy editor of various journals. She has many publications to her credit, and she has even received a gold medal in her DM. And also, she is a resource person for Supreme Court consultations. She has numerous publications to her credit. And one interesting thing is she is a Carnatic music vocalist as well. Over to you.
Thank you, Dr. Shruti. A very good afternoon to one and all present here. I thank the organizing team for giving me this opportunity to speak with you today here on a topic that lies at the intersection of physical and emotional health, which is pain, right? So pain is not just about fractured bones and healing wounds, especially in children. It's also about how the experience influence on a developing child's mind and emotions, and what impact it has on the child. So today I'll take you on a very quick journey to understand this deeper layer of pain by very briefly looking at what the research says, which is obviously aligns with what Professor Stephen was mentioning, and of course after the very thought-provoking lecture by Professor Stephen on why and does pain really matter. We'll try to talk about how and why the deeper layers, as in the emotional impact of pain on a developing child now. So even by definition, see, pain is an unpleasant sensory and emotional experience, right? And one of the six notes that were recently added to this expanded definition also says that pain is always a personal experience, which means it's subjective. Subjective, not only in terms of the perception of physical pain per se, but also its experience, which the child, how the child makes sense of the situation and what's really going on around, and how is the child able to cope with it, which is what very beautifully the videos had illustrated to us in the previous talk, that it's not just pain but beyond that, you should think beyond pain, what is going on. And that was more say in a notice setting, or but even otherwise, especially children who come to you with chronic pain and have repeated admissions, just imagine what's going on with the child through this entire process. So, how is the child really coping with it, and what sense is the child making out of all of this? Now, therefore, especially because it's, as you see it, that it's influenced to various degrees by varying degrees by biological, psychological, and social factors, that early pain experiences can leave lasting marks on emotion regulation and coping skills. Now, very quickly, what research says. As you see, it's all about chronic pain. What about acute? Well, even acute pains, be it due to injury or post surgery, does have impact on a child's behavior, similar to chronic pain. However, most of the research here focuses on chronic pain because of its association with long-term psychological sequelae, and it generally examines through a life course perspective, right? And you are the pain experts here, so chronic pain is pain which repetitive pain that lasts for 3 months or more. And we know by nature pain has a protective function, but beyond the point, when it becomes chronic, is it really doesn't serve that function. Now, what does research say here? So here, various teams have identified that there are many factors associated with chronic pain in children and adolescents, such as physical disability, low self-esteem, then the tendency to catastrophize pain, adverse childhood experiences, school-related stressors, chronic health problems, fatigue, insomnia, and so on. So these are associated and not really correlated. Now, moving on further, chronic pain also is linked to psychiatric comorbidities ranging from emotion dysregulation, social withdrawal to clinical anxiety and depression, and even post-traumatic stress disorder. Now, what's important to note here, and if you note down in that second, part there, all the other confounding factors were controlled for, and even after that, they found significant association with psychiatric comorbidities, and that is where we need to note that these psychiatric comorbidities in turn exacerbate pain symptoms, reducing quality of life, may delay or prevent recovery as well. Now, it's not the pain per se, but the combination of pain and impaired psychological functioning during childhood that predicts co-occurrence of pain and mental health disorders in adulthood. Now, there are various theories that have been proposed, on chronic pain and related psychiatric conditions. Now, one that is mutual maintenance theory by Sharp and Harvey. It suggests that basically if a child has chronic pain and psychiatric conditions, both of these things reinforce each other. And that is because of the common neurobiological, cognitive, emotional, and behavioral substrates. As you can see, they're all listed out there. For no want of time, I will not go into the details. But largely it talks about the common substrates and doesn't comment on the causal links. Now, there's another theory called shared vulnerability theory. Now, shared vulnerability theory means in children with pre-existing vulnerabilities, such as, say, low threshold for arousal or anxiety sensitivity. Now, anxiety sensitivity means perceiving normal bodily sensations as painful in an anxious state. Now just imagine now all of these children who are getting little pricks for vaccination or other reasons, they would be anxious. So even a normal sensation may be perceived, and especially if a child is prone to have this as a trait, not all children will have, but as a trait, then it's going to be higher. So these are some common vulnerability factors for children to have pain, chronic pain, and post-traumatic stress disorder following any traumatic event. Now, in the context of trauma, there's another theory called the perpetual avoidance model. Now, this says any trauma obviously leads to hyperarousal and avoidance, and it is the avoidance that maintains pain and psychiatric symptoms. Now, Holly et al. They have proposed pediatric specific model. Now, what they say is that in children especially, pain is very complex phenomenon. And why so? Because children have developing brains, and as you've seen already, they may have, thin cortex and lower cerebellar volumes. Chronic pain can lead to these, developmental problems or, different path of development in on the developing brain. The child who experiences this. So the fact that children are still developing, pain can have adverse impact on the developing brain, and they also have setbacks in their social domain or social setting, wherein there may be problems. We'll, go into the details in the subsequent slides, but there may be problems with their peers and others, which may lead to emotional problems that will again, worsen the pain symptoms. And family dynamics also play a huge role. So they have tried to integrate basically the individual, interpersonal, and neurological or neurobiological factors to propose a more comprehensive model, that is the pediatric specific model, to understand the links between pain and psychiatric comorbidities. Now moving on to how pain influences development. So you want to see the middle one there. So pain, chronic pain, children may have fatigue. There would be low levels of energy, enthusiasm, preventing them from engaging in social activities or play. And that in turn may cause feelings of isolation, loneliness, difficulty integrating with peers, sense of alienation, or the condition not being understood by others. Uh, the chances of being bullied or getting bullied are higher, feelings of frustration and inadequacy. And while pain in itself can cause difficulty focusing on studies and impaired concentration, but all of these things are actually, as you say, are interrelated. One will again, lead to the other and tends to get a vicious cycle there. Can lead to difficulty completing assignments, missing school, falling grades, and while pain can have all of these effects, and one must also remember that the reason for pain, we are not talking about the reason for pain or haven't even mentioned so far. Whether it's injury or illness, that is also traumatic to the child. And these two together, it would be multifold effect on what the child is actually experiencing here. And all of this can cause this, and in addition to the pathway of sleep, and lead to again physical deconditioning, and that harbors fear of pain, avoidance behavior. Again, there's a vicious cycle there. So all of this, one feeding the other, you can see that major domains of development are already affected. Physical, social, emotional, and cognitive. And especially when you're talking about a growing child, the child may have a feeling of being different from others or inadequate as compared to peers, which leads to a negative self-esteem and therefore impacts the identity formation adversely as well. Now, after saying how it influences, moving on to what. So this is more temporary. Temporarily it may be lying on a spectrum from immediate to long term. Now, immediate child may have fear distress around the medical procedures, sleep disturbances, more in the short term behavioral problems such as irritability, aggression, avoidance behaviors, avoiding school, socially, as I told you, isolating themselves from peers, adjustment disorder, depression and anxiety. And when I say this is more clinical diagnosis of depression and anxiety, and not, I feel depressed today, so I'm depressed. And long term, there is higher likelihood of experiencing post-traumatic stress disorder, especially if pain follows a traumatic event. And poor problem solving skills, emotional dysregulation, maladaptive coping, which may even lead to substance use and suicidal behaviors in adolescents. Now, this is the last slide on management. Now, pain tends to have this ripple effect, as in we've seen it negatively impacts the child's overall well-being and functioning, both in social situations and school setting, academic, difficulties and all that we've seen. And it can also have effect beyond this in terms of affecting all the other family members, including the siblings. Siblings may have a feeling of confusion or being vulnerable or feeling neglected by parents. And parents themselves have this caregiver stress and burden, as you've seen related to on the studies where they want the parents to address the problem. So beyond the pharmacological, non-pharmacological approaches that were we generally use for managing the pain, we may tailor psychological interventions which could be play-based, mindfulness-based, or cognitive behavioral therapy, which is more developmental, age-appropriate based, identifying that. And of course, with parental support, so it calls for a collaborative care. Now, I would like to very quickly mention one of these cases that we had seen that I was reminded of while I was seeing the previous, presentation. There was a 2.5-year-old child who was sexually abused by a school van driver, and it was a penetrative sexual assault. And immediately after that, parents had taken her to hospital. She underwent a lot of investigation, sampling, and post-exposure prophylaxis and all of that. So we continue to see her for a really long time. She still comes for follow-up occasionally, though now, and she's doing pretty well. But for the longest of time, she still had fear of hospitals. Now, at that age, pain doesn't encode in the form of language in their memory. So it's more, sensory memories. So especially when you're working with children, which is why play has a role or other, creative modalities, because they will not be something that's not encoded as language, cannot be expressed. And also that, one needs to get to the level of a child. To meet the child where they are, you have to use more child appropriate ways to, really connect with the child. But all of this put together, it's really difficult even for the child to understand what they're going through. But for the experience that she went through in the immediate, part of that event, aftermath of the event, she was scared of this needle pokes and any hospital setting or the smell of it. So the sensory memories could be anything to do with touch, skin, smell. So all of those things, and which is where it leaves long-term scars on what happens. And just imagine again, it's not just the pain, but the child who has undergone the abuse, or for that matter, any other cause for pain. So we cannot discount, or one plus one doesn't become two, it may be 22. So it's hard to really, connect and do a diagnosis is also not enough. So it's important to really understand and meet with the child where they are, and more importantly, the child should also feel heard. So which is where I would like to end by quoting Canadian physician Gabor Mates. Words children don't get traumatized because they are hurt. They get traumatized because they are alone with the hurt. And they often start to heal once they feel they are heard. So it's important to connect with the child behind the mask of pain to really help the child to heal. And I thank you all for your patient listening.
Thank you, ma'am, for elaborating us about the effects of pain on child psychology. I would like to call upon Dr. Mahante sir to give away a token of a memento to Dr. Shravati. Next, I would like to call upon Dr. Sheetal, our Associate Professor, Department of Pediatric Anesthesia, to talk about the chief guest, Dr. Sanjay.
Hello everyone, and welcome to the event. No event is complete without mentioning about our director, Dr. Sanjay T.S. Dr. Sanjay is our blood director, and he runs a fellowship program in development and behavior of pediatrics. He has received Shikshana Ratna and Sanjeevani awards. He has many publications, national and international. He is involved in many childcare activities. In IAPA, he has been the executive member for 3 times. He is also the executive member for the infectious disease chapter. He is also the zonal coordinator, IAPA Infectious Disease State Branch, and he is also a treasurer for National Conference of Adolescent 2006. Dr. Sanjay, our director, is not in town, otherwise he would be more than willing and pleased to attend this event.
Thank you, ma'am. Next, I would like to call upon Dr. Anuradha, our Associate Professor, Department of Pediatric Anesthesia, to introduce Dr. Gopakrishna Pillai.
My coordinator will just.
Okay, sure. Yeah. We'll just wait for you to come back. Alias, we are still having.
So we can start.
The past 2 months I was in Hyderabad, and that's when I had an opportunity to even know about this foundation called OBLF, the 1 Billion Literates Foundation. So that is how I got in touch with Dr. Gopakrishna Pillai. It's my honor to introduce sir today here.
I really like, I mean, he sent me this vast profile of this. It says that, he's been 15 years as a healthcare provider. He's a specialist in palliative and old age care with demonstrated expertise in health system, strengthening for vulnerable populations. And I'm in love with this personal mission statement that says that he wants to collaborate with individuals, organizations, and innovative businesses that are working to strengthen the existing healthcare system, especially in a country like ours, which is so badly needed. So thank you so much for, accepting our invite and coming here. Just a brief about Sir. He, after completing his medicine from University of Kerala in 2009, he has completed various degrees and currently he is a Master of Public Health from Amsterdam in 2019 and also Master of Science in Vitality and Aging. He has many awards and publications to his name. He's also member and subcommittee member on elder care public health policy task of government of Karnataka. He's an associate center for law and health Central Law University at Kerala, and currently Sir is heading the public health initiative as a director of the 1 Billion Literates Foundation. I please invite Dr. Gokushna to like to talk about the 1 Billion Literates Foundation and the work that amazing work that he's doing with it. So we'll just take 2 minutes to bring up the slides. You can come. So you can come and speak. Yes. We would love to hear your impromptu speech also. Because I think our first conversation was on the phone and I heard that is when I went back and Googled and looked about what you're doing. Thank you so much.
So before I start, I need to, I would like to give a very sincere appreciation of all the organizers. I'm not taking any one person by name, but all the organizers who have made this possible and who reached out to me and enabled me to have this discussion with you. So before I start, I will not be going anywhere near pain and its management because I know the audience I'm speaking to. So I will not go there. But let me try and speak about palliative care. Um, so when we speak about pain and palliative care, what would be the differentiate? And I would really like in the limited time we have, if we can make this interactive, what would be the differentiation between pain and palliative care? So if pain is the work we do, then why do we need palliative care? Have you thought about that? Can anyone try to share your ideas about that? There are no bad answers, right? There are no wrong answers, right? Anyone wants to make a guess about why would we need palliative care when we have pain? I love boys there at the back. I was there all the time.
The one with the basket.
No, I was generally outside. But when I was inside, I was at the back. So yes.
Yes, both.
Why do we need palliative care when we have so much expertise in pain management? So I just want to share a story. No, not this one. Not this one. So there's a girl, Mahalakshmi. She's 17 years old. She lives in Anekakaru. So she lives in the village of Telagarahalli. At the age of 12 years old, when she was about 12 years of age, she developed what would later be determined to be an anatooccipital joint dislocation. So it would start, I think this is the first one. Yes, that. Yes. So it would start as a numbness, a tingling sensation on her hands, and she was, I think, 9th standard at that time. it progressed over a few months to a point that she eventually, over the course of a few months, became completely bedbound. And from the age of 12 to the age of 17, that she is now, this is her life. So she lives with her mother and a family, but father is usually in the fields. They're a farming family, like most of them. She has a mother that you can see there, and there is a younger brother. For the past 5 years, now this session is overwhelmingly, we have many more women here. So imagine your own lives from the age of 12 to the age of 17. At the age of 12, you are a child. At the age of 17, you are a young adult with ambition and dreams. This is her life from the age of 12 to 17. If she strains to the left, so I'm taking this picture from the door, right? If she strains to the left, but she has to be careful because she cannot move it so much. What she can see is two dirty plastic buckets under a tap. That is Mahalakshmi's view of the world for the past 5 years. This is not a girl who is in a lot of pain. This is a girl and a mother in intense suffering. So the first point that I would like us to reflect on is the distinction between pain and suffering. Failure to manage pain definitely leads to suffering. We heard that over and over again, and that cannot be emphasized more. But the lack of pain does not imply the absence of suffering. And palliative care is in the final, in the final analysis, palliative care is that discipline within medicine, but also those principles of medical care that are fundamentally oriented towards the prevention and alleviation of serious health-related suffering. The Lancet Commission describes serious health-related suffering as the combination of physical, psychosocial, emotional, and spiritual suffering that results in the context of an acute or chronic life-limiting illness, injury, or disability. Pain management, like we saw earlier today, is a lot more than management of physical pain. Pain is spread across the dimensions of physical, spiritual, psychosocial, and emotional. And even in the absence of pain, pain can be an individual experience, although it seldom is. Suffering definitely is not an individual experience. Suffering is always a group experience, it is contextual, it is spread across the community. Which then brings us to the context of what does it mean from the population perspective to try and develop pain and palliative care services. So I need to apologize, I was a little slow here. I didn't check whether we will have a screen and whether I should bring a deck. So I'm repurposing a deck that we had for another purpose, which mostly covers the. So that's Martin Luther King. So we have been working in Anekal Taluk, 1 Million Literates Foundation. Most of our work is, and as the name suggests, it was and it still remains an education focused NGO, in the sense that the presence is much more in education than in health. Health work is fairly recent since COVID-19. We began with primary healthcare work, which is community-based, focusing only on 2 panchayat areas, 30 villages. The work iteratively led us to understand gaps in the population. So first it began with COVID. During COVID, we realized how broken the public health system is even without COVID. And then we started primary healthcare as a way to address some of those with their focus on large and NCDs. We realized the gaps in the community on specifically on geriatric and palliative care. So you will find that the other picture that we saw briefly, like so a couple of us sitting down. So that picture shows essentially what happens every 45 to 60 days in the villages. The primary healthcare team goes to the villages. They sit in a space that the villagers says convenient and comfortable for them. It can be under a temple, under a banyan tree, in front of a school on Sundays. Uh, we deliberately made a decision to sit at the same level as the population. So it's not like we sit inside an OPD with our shoes on, and the patient stands in front of us without their shoe on. Right? Everyone sits at the same level, and that is extremely important when it comes to uh, understanding why people do the things they do and how we can help them to change behaviors. It starts by meeting people eye to eye at their level. We realized the gaps in specific high gap areas like mental health, like palliative and pediatric care. We started programs to address those specific gaps. And specifically, the geriatric and palliative care program itself, which began as an offshoot of the work in the 30 villages, has since, so this is the evolution of ODL's journey, right? Has since evolved to cover all 200 plus villages. When I say villages, these are not revenue villages, these are not panchayat, these are the hullies, a population of 800 to 1200 sort of places. It now covers all the 227 villages of Anekal Taluk by a mix of outpatient, home care, and telemedicine. Our outpatient, we have one center, which is a geriatric and palliative care center, and I will briefly touch on why that is important. But we also run our OPDs within the public health system, so we run our OPDs from some of the PHCs we work with, and we have also been recently invited to set up an inpatient unit within Sindhiraman General Hospital, which we expect to come to. So the goal is not to create parallel systems, but to create capacity within the existing system. So the public health strategy that I described, as it evolved and emerged, and now where it is. So the program is data driven. It has to be because we depend on funders and they need to see some of the data. But we try to go beyond that. So the funders have a very small set of requirements, but they actually use the data to drive the gaps, and we look at the cycles and how we can iteratively improve on that. So this is just one patient as an example of the kind of work that we do. And this is a person who was identified to a primary healthcare team, and he was essentially, he had a stroke, but nobody had seen to him because of his house is like out in the outskirts of the village. So when we first met with him, so why this is important is we started as a palliative care program, but at a population level, you always have to be ready to let the field guide you, and we realized that this is what the community needs. Right? The community needs, yes, palliative care, but there is way more need or unmet need for regular geriatric care and rehabilitation services. So we made a pivot towards including those aspects of geriatric and rehabilitation also into the program. So essentially what we have now is we engage with the panchayat. So when we go into any community, we engage with the health system, we engage with the local government, and we engage with the civil society such as it is. So if there are, and we are very agnostic. So if there is a group that is maybe around a family group or an actor, we will engage with them also. As long as it's not a group of people sitting around only for the purpose of smoking and drinking, we'll engage with them. Sometimes we engage with these days. So it's a nurse-led approach, and when I say nurse, I use the term expansively because we have our trained nurses. We also have our community health nurses. So, and it's very important in the sense that they are always taken from the communities where we work. So they have ownership. They identify with the community, and they can take ownership of their own community. So these are nurses who are taken from the community, and we screen patients based on the pre-selection from the community. So we don't go door to door. But we do get sense from where the patients are likely to be. And we have a screening protocol which helps bring them into either a palliative program or a geriatric program, as I just described. And we leverage the government system. And we also have a school health program where when you're working with children, it's the greatest opportunity to help provide positive role models and a template for healthy living. So we just come down to that. So this is what all of this comes down to. Our work is
It's essentially taking the population as the base, not the hospital as the base. The population as the base, starting from the general population that is without any non-risk factors, children, for example. So in them, what we focus on is health promotion and disease prevention. Like if you can stop them from becoming alcoholics in the first place, right? That's the best intervention from the public health perspective. Then we have the primary healthcare team which focuses on early detection. We have cancer screening programs also in partnership with the Indian Cancer Society. Rehabilitation and palliative care come towards the fag end of the care, which are essentially for patients who have progressed beyond the stage of just focusing on the treatment of the illness, but you need to also focus on what I don't explain. So essentially, we have two tracks: the geriatric track and palliative care track. The geriatric, so essentially, we both look at both with the same set of resources, which is the multidisciplinary team comprising of. So the nurse-led team takes lead of palliative care. The physiotherapist team takes lead of rehabilitation and geriatric care. The work is essentially the same, but the goal of care is different. In that, in the first group, there is an expectation that there is functional improvement over a period of time. In the second group, the goal of care is prevention and alleviation of suffering. So that has practical implications for how intensely, for example, we put someone on a rehabilitation track. How do you define success? Because if you don't define success in some way, you will never know when you have failed. And inability to know when we have failed is one of the biggest drivers of harm in the healthcare system. One part of it is that we define all death and dying as failure. It is not. Like I said, it's not just to children. The trauma happens because the suffering is unrecognized and not acknowledged and goes on for long. So it is possible in palliative care and one of the real value additions that palliative care teams can bring to institutions such as these. See, it is one way to look at palliative care team as an isolated department within another institution. But there are principles of palliation that, if applied across the setting, can improve the quality of care at all stages of illness. I think this is fine. Do I have another couple of minutes? I don't know because I have been watching the time. Are we out of time? We're out of time.
Just one more.
Right? Okay, good. Chalo, thanks.
Thank you so much, Dr.
Thank you so much, sir, for enlightening us on this topic today. I would like to call upon Professor Dr. Chandrakala ma'am to give away the memento to Dr. Gopakrishnan.
I think we're finally going to the much awaited talk from Anya.
I would like to call upon Ms. Anya to continue with her talk.
It's open. Yeah, I think a big clap for the video.
It's out of all the things that I did not expect to know about this, for 5 minutes. Good afternoon, everyone, and thank you so much for taking the time to listen to me talk about play therapy and how it can be used with children who have pain and palliative conditions. So I know we've been waiting for a long time. I'm so sorry to be Okay. So just a little bit about why would we even think about play therapy for children in pain management? As you can imagine, it is a daunting reality. These children are in pain, they don't know what's going to come. Are they losing a limb? Are they losing their lives? How is their life going to change? In the short term, in the long term, what are they missing out on? They carry a very heavy emotional burden as well. Just seeing their parents worrying, carrying their own anxieties on a daily basis, um, losing out on a childhood and the ability to, um, um, go outside and play like any other child. So, now what is the difference between play therapy and play? The difference is the goal. In play, there is no goal. The goal to play is to just play. It's to use your skills, your imagination. There is no goal. But the goal to play therapy is healing. So in play therapy, we believe that play is a child's language and toys are the child's words. Every mammal, as you'll discover, as children, they explore, they express themselves, they learn and develop through play. In play therapy, the toolkit that we use sand trays, we use toys, we use movement, music, drama, puppets, storytelling, art, and here is this video I'm going to play. Okay, unfortunately, I don't think this video is going to play. So we also have miniatures like vehicles, animals, dolls, and a dollhouse as well. So now, in play therapy, one of the things that we focus on is on creating a consistent, predictable, and reliable environment for the child. And this is because we specifically designed the play therapy room to be child friendly. It is warm, it is welcoming, and there is a lot of safety, psychological safety to be found in something that is familiar, something that is consistent, that does not change. When there is so much of uncertainty and doubts and questions around the child's environment, their bodies, they just don't know what's happening. When they come to the play therapy room, it is very soothing to know that every single time I enter this space, it looks the same. The same toys are here in the exact same space. The rules do not change. But when I tell a child that this is your space, I mean it. So I tell them, when I tell you that this is your space, it is not going to change. This is your space. There's a lot of sense of safety in play therapy, and one of those is when a child plays out their experiences in play therapy, they are projecting their experiences and their emotions onto the play. So, take a simple example. We've all played teacher student growing up. Very often we've played out a strict, mean teacher. Why is this? Because a lot of us have experienced that strict, mean teacher. And then in play therapy, you'll notice that the child, after he has played out this observation and experience of the strict, mean teacher, there is a shift. There is a shift where the child starts to wonder, okay, I'll forgive you. It's okay that you didn't bring your notebook to class today. You can bring it tomorrow. I don't do it again. I'll let it go this time. The child is exploring how the things have gone differently. They're working on the experience of closure in play therapy. So in play therapy, the thing is we don't want therapy to be overwhelming. To begin with, there's a lot of mental health stigma, even for adults going to therapy. And for parents to trust their child with a stranger behind closed doors is a big deal. So we, of course, design the room to be child-friendly, warm, inviting, but also when a child plays out their experiences and they're looking at it and it's being projected onto a toy or in a sand tray or in a story that they built, there is that emotional distance. There is some safety. It's not overwhelming for the child. When I say that play therapy is child-led, it's extremely important because I will very often meet a parent or even a doctor and they tell me these are the symptoms they're seeing, this is what the child is going through. So when the child enters the room, I don't ask the child, so what happened? Why are you fighting with your brother? Why giving your mother such a hard time? Why won't you just be still in class? We allow the child to let themselves become become known to me. And there's a lot of knowledge in that. How does the child want me to see them? Very often I've seen children who want to be liked. So they'll flatter me, they'll compliment me, they will be very respectful, very polite, very well mannered. They'll ask me for my opinion. So, do you like my drawing? What do you think? And then of course we reflect back to the child. I wonder what you think of your drawing. You know, we allow the child, when we tell the child this is your space. We also tell the parent, please don't tell the child what to play with, what to say, because we want the child to be able to come into the room and explore as they want to, process whatever emotional burden is on their mind that day or that week. It is the child's space to be who they want to be. So unfortunately, my video of my playtherapy room didn't play, but here are a few pictures of what I have in my playtherapy room. We try as much as possible to have wooden toys in natural elements. So you have some coral that I carried with me from Bali, some seashells, some driftwood at the back of it, pebbles, stones, rocks, and pine cones. The idea is that these miniatures are usually played with in the sanctuary, but like today, a child created a scene and she did not put the toys in the sanctuary, so that was fine as well. The idea is when we have children engaging with natural elements, it helps the child engage in some form of outdoor play, some form of grounding as well. So here we have the kitchen set, which is the most popular part of my play therapy room, and I will take you down a path today of how the kitchen set became the site for a clinic. So these are some more. The kitchen set, all the gingerbread house, cake, ice creams, all of it is very popular. The tea, cupcakes, coffee, vegetables, fruits, being able to cook in a pan. That's the art and craft trolley. And these are some toys, the dolls, and it's really important to have a variety of toys and dolls for representation and also for a child to be able to use their imagination. Of course, we know that a stick can become a wand, it can become a ruler to hit someone, it can become a broomstick to fly with. So you don't need to have every single thing in your toy room, but it's nice when you do. So I have some astronauts, I have a scary looking henchman, I have some soldiers, skulls, ninjas. Here, I just want to point out, I wish I had taken a close-up, but if you see the Batman right at the back, he's missing an arm. And his arm is there next to him. A child unfortunately broke the Batman by mistake. We try our best to keep broken toys in the playroom. Toys that look old, toys that have been used. So a lot of the toys that I have in my playroom are not new toys. And there's a lot of familiarity and warmth that comes from used toys. Because it says to a child, you're not new, you've been played with, you have a story. And a toy that's been broken can very often represent a broken part of a child. Maybe in your situations, it could be a child who's lost a limb, who might fear losing a limb, who's had a fracture, who's had a fall. So now what happens in a play therapy session? So here in the picture you'll see I have some toy hospital instruments, like an injection, a doctor, some medicines, a stethoscope. So, of course, it's important to have medical toys, and it's also important to allow a child to touch medical instruments that are being used on them, to play with it, to turn the buttons on and off. It makes it far less scary when they're at least able to touch it, to get to know it, to break that barrier. Children also get to develop a sense of control when they're able to develop a sense of psychological safety, they're able to get their answers questioned, they're able to play out their experiences in the playroom. There's also a lot of sensory and messy play that we encourage in play therapy, and this helps children ground themselves. This helps them explore different tactile stimuli. Very often a hospital is a very different environment for a child. It smells different, it sounds different, it looks different, its structure is different. So in the play therapy room, when the child comes, not only is it stable, consistent, but there's also clay, there is beeswax, there is the opportunity to finger paint, there's a sand tray. So this just allows for a child to return to what it feels like to be a child and also engage their physical senses. Of course, in a play therapy session, when it comes to the imagination, it allows the child the ability to let go of their parents' worries and stress back home. This is a space where they can just be who they want to be. They get to carry what they want to carry into the playroom. Maybe they want to bring in their parents' stress and how they worry about their parents stressing out, but they might also just want to come inside and just be themselves. It gives them a chance to engage in some form of risky play, even if it's just vicariously, where they're playing out the idea of being this superhero who's out there to fight the bad germs. A child who's wants to climb the tree, and so they take a little miniature and they tell me a story. He's climbing the tree, he's falling down, but it's okay. He can get back up and he can try again. His parents are right there watching and they're so happy, they're cheering him on. So children very often build stories that they wish they could live out, stories that they wish had gone differently. And sometimes they even play out exactly the way it happened. So just this morning, I got very lucky to have had this experience just before our session today. A 10-year-old girl whom I work with came into the playroom. 3 weeks back, when she came in, she was really sad. She was looking at the floor, her voice was small, and she said, after this, I have to go to the doctor and get my eyes checked. I really don't like getting my eyes checked. They put drops in my eyes, and it's really scary, and I just hate the entire experience, but I have to do it. And she was really, really sad about it. The week after that, she said she had to go to the hospital to get some vaccinations. And again, she looked at the floor and she was really sad about it. So then this week when she entered the playroom, it was really interesting because she picked up a storybook called Holden Pot. Do you mind going to the next slide? Yes, this is the storybook. And after she read the storybook, which is essentially, as you can imagine from the picture, holding all your emotions in until you burst, right? So after she read the storybook, she picked up some of these medical toys here, and she said, "We're going to go to the clinic. Here is the clinic." And so you'll notice the kitchen set became the clinic, and she played out using the medical instruments, and there's a red stretchable toy there. That's a regulation toy. And she used the dolls and the stuffed toys and the kitchen set, some books and some other tools as well to hammer with. Now, I'm just going to take you down exactly what happened. I said now one thing we do in play therapy is we're working on regulation, right? So what is regulation? Does anyone here know? What is your concept of regulation? What does it mean to be regulated?
You expect them to follow certain norms or
Uh-huh.
certain behavior.
Okay. Mhm. Okay, so in therapy, when we use the word regulated, what we mean is that I am present or I am mindful. I have the capacity to be 100 on 100 mindful or even 5 on 100 mindful. But it is building that capacity. And how do you build that capacity? By knowing what your body is feeling and knowing what you're thinking. It's by bridging the mind and body connection, by strengthening the mind and body connection. Because once we are self-aware, from there we can act in a more regulated manner. I might still choose, even though I'm regulated, to break the glass because maybe that's what I need in the moment, but I am still regulated. So now she tells me, okay, we're going to go to the clinic, and I said, oh my God, the clinic? I don't want to go to the clinic. What? Why do I go to the clinic? I don't want to go to the clinic. Now, it might seem like I am attaching ideas and emotions to her play. What I'm doing is I'm playing out the feelings that I know she's experienced by telling me how she feels about going to clinic before. And I said, okay, I know I'm scared because my voice is changing and my stomach is feeling tight and it's not that easy for me to breathe right now and I'm really nervous. And she looked at me and she looked disappointed. And then she took out three stuffed toys and she gave them to me and she said, here are some stuffed toys. They'll keep you safe. You can hold them. And so I hugged them and I said, that really makes me feel so much better just touching them because they're soft and they're furry. And again, now bringing up the tactile sensation and naming how it makes me feel is another way of helping her co-regulate. So by me modeling regulation, I help her co-regulate. She's learning how to do this for herself. She's empathizing with me and she's saying, okay, so when it's furry, it feels better. When my stomach feels like that, it means I'm sad or something is going on with me. Um, hold on. Okay. So she then brought a doll, and she said, I'm going to first show you what I'm going to do on the doll. I'm going to fake show you what's going to happen." And she literally took the doll and she said, "So I'm going to use this on you. I'm going to use that on you. This is what it's going to look like. This is what's going to happen." And I said, "Wow." I feel so relieved. Like my stomach is breathing a lot easier now. How did you know? How come? And she says, yeah, my doctor, when sometimes when he tells me what he's going to do, it makes me feel a lot better. But sometimes they don't, and I'm just like, what? Like, how could you just do that and not tell me what's going to happen, what it's going to look like? So she's also using from her experiences, she's processing what has gone well for her, what has worked for her. So I said, okay, so you're telling me that you know what works well for you, and you know what just scares you and what's not okay for you. She also then, if you see those three stacked up cushions on the floor, that was where she had me sit. And she said, okay, one cushion's not going to be comfortable for you. Okay, let me put three. And it might seem like a small thing, but this is a child who's taking the time and the effort to make me feel comfortable in the clinic. Who's built this clinic environment and is telling me here, you're not going to be comfortable there, let me make you more comfortable. I prioritize your comfort. I want you to feel safe. I want you to feel okay. So she's done it on multiple levels and she's working on it and she's working on it. And so finally she starts to feed me and I'm sitting there and I'm thinking, okay, maybe the play is changing. But then based on what I read and also what I realized is that she was just taking the time out to say, okay, you're in the clinic, you're getting comfortable, your anxiety is easing, now let's just chill. Would you like a cup of coffee? Would you like some cake? How would you like your coffee? Do you want an Americano? Do you want a latte? Do you want a cappuccino? We did all that. And what's really interesting is, as I fast forward, you'll see that part of the kitchen set is, there is a tap and a basin. Okay, so those were the medical toys that she used. Those are the stuffed toys. And here in that basin, she said, okay, so this is for you if you need it. And I was like, what if I need to throw up? Because this was in the beginning. And I said, because I am nervous, I feel like I might throw up. She said, yeah, if you need to throw up, you can throw up right there. So it's wild to see how kitchen set became a clinic in such a sense. And that was the doll that she used. And she used to show me what she's going to do with the doll. So then finally, through the kitchen play, she said, there's magic and don't worry, I know you're scared, but I have numbing cream. And if you saw, there was that wooden paste-like bottle I wanted, and she said, this is the numbing cream. So I know you're not scared anymore, and I'm telling you, you don't have to be scared, but it hurts. I can use the numbing cream. And there's a lot of magic in this room. There's magic in your coffee. There's magic in the sprinkles that I'm putting in your coffee. You're going to be okay. And there was even an injection, and I said, I'm really scared of needles. I'm really scared of needles. And you keep using the word blood. I'm so uncomfortable with the word blood. And she said, I know blood is scary, but I'm going to tell you how it's going to work. Now, see here, if I take this much of blood, it means you're okay. But then if I get this much blood, it means you're not okay. And that's when I would definitely use the numbing cream. And she said, look, I want you to look at your blood because if you see white spots in your blood, that means you're not okay. So it was really, really beautiful and amazing to see this child bring out her entire medical experience in a play therapy setting. So now how does play therapy help with coping with psychological and physical pain? So we know that play releases your happy brain chemicals and those flood through your body and your nervous system, and so they offer some relief, not just psychologically, but also we know that there is a mind-body connection, and that when we are less stressed and when we are happier, we tend to perceive our pain as less as well. So there is a perception of pain that can be exasperated based on your anxiety and your stress, or conversely based on how relaxed you are. Um, Play therapy also helps a child feel empowered because it gives them a chance to be themselves, explore, process, gain that sense of control back in their lives when they're in a hospital and there are all these adults telling them what to do, sometimes not explaining things, um, maybe forcing him to sit down and take an injection. This is a space where a child gets to do things differently. And you'll notice that toy there has a broken arm. Yeah, go on. Okay, so now what is the role of a play therapist in a play therapy room, right? Like, can't anyone be a play therapist? And yeah, you can if you want to go ahead. But the biggest thing we do when a child enters the room is we build a warm and friendly and trusting relationship with the child. We can have all the toys in the world, but the biggest toy in the play therapy room is the therapist. Because that is where the therapy is happening. It is in the therapeutic relationship where the healing is happening. So we build a good rapport with the child. The therapist is accepting of all the emotions that the child wants to bring into the room. Accepting of anything the child wants to say, accepting of the child's play entirely, even if it doesn't make sense. And the therapist is also permissive, which means that I have very few rules in the therapy room, which is just the sand stays in the sand tray, and we keep each other safe, ourselves safe, and everything safe. And so it's a very permissive environment where the child finally gets to be in a space where he actually gets to make the rules. This is actually his playground. And it's very powerful because then the child is truly exploring how they can express themselves through play, what they have to say, what are the internal stories. And because it's such a subconscious, unconscious process, there's a lot that comes up to the surface. And that's where therapist's role as being insightful. The therapist needs to be present to what it's bringing up in the play. The therapist needs to be able to relate it to what is the child's symptoms, and the therapist needs to be able to reflect that back to the child. Okay, I'm seeing that you're you seem angry with the doll. You're banging the doll on the floor. Okay, I wonder how that's making you feel. Are you still really angry? Do you need to beat it down some more? Are you getting that frustration out of your body? Are you feeling lighter now? We need to be able to give the child insight also. For example, this one time I saw a child who had issues because her mother had had a baby, and she loved her baby brother, but she was also angry. So we were serving tea to the stuffed toys once, and she threw all the baby stuffed toys off the mat. She said, "No babies, no babies." And all of a sudden, this calm, happy tea environment, this child was screaming. She was 5 years old and she was shrieking, and any small stuffed toy became a baby. So then it's my job to reflect, okay, I can see that you don't like babies. We don't want babies in the room. We're not serving tea to the babies. The babies are not welcome here. There's a lot of power in naming what is coming up and bringing it to the conscious surface. Because once we can be aware of it, we can work with it again. But at the same time, we need to recognize that play therapy is a gradual process, so we don't push it. I don't think, okay, I know what the child needs. Let me get in there and control the play. Let me tell the child what to say. No, your mom does love you. She didn't mean to say this. She didn't mean to hurt you. You know, we need to also be sensitive to the fact that how much is this child able to hold? What is this child's window of tolerance? Yeah, I can go on sometimes. Yes, and of course, patience and setting just the basic limits and being patient, waiting for the child. Knowing that each one's process takes their own time. Healing is a journey, and we have goals, but the destination is really the goal. So in conclusion, there's a lot of value in play therapy and in using it with children in pain and palliative conditions. As you can see from that image, it allows children to be who they want to be, escape the hospital environment, escape their daily, their daily pain, the weight of their emotions, the burden that they're carrying, their parents' stress, the smell of a hospital, the being in an overly sanitized space where they can go to a play therapy room and, of course, if the doctor permits, based on the child's immunity, play with the sand, play with the clay, be messy, um, imagine, just at least in their imagination, climb a tree, recapture some part of a childhood that they have lost. Thank you so much. Anybody have any questions?
And will we be able to use your services in the hospital?
I desperately hope so. I would
Thank you
love
so
to.
much.
Thank you so much, and I'm very sorry again about the inconvenience.
No worries, sir.
Thank you, Ms. Anya, for telling us a lot about play therapy for children with pain and palliative condition. I would like to call upon our Professor Dr. Chandrakala to give away the memento to Ms. Anya. Now we have come to the end of the session for the day. I would like to call upon Dr. Sharda N., Assistant Professor in the Department of Pediatric Anesthesia, to deliver us the vote of thanks.
Good evening, everybody. I hope you had a very good time enjoying this session. And I also stand here today to express my heartfelt gratitude to everybody who made this event successful. Uh, I express my gratitude to Dr. Stefan for being with us virtually today and for sharing his experience and enlightening us in the most informative way. I extend my gratitude to Dr. Shravanti for being here with us today and for her informative talk. I also extend my thanks to Dr. Gopi Krishnan Pillai for being with us today and for his wonderful talk. And I thank Ms. Anya for being with us today and explaining about the child play therapy, children play therapy in a very expansive way and which was very enjoyable. And I also extend my gratitude to uh, all the department staff, especially senior professors, Dr. Anuradha ma'am for leading this pain and palliative event. And I also thank all the all the fellow doctors, surgeons, nurses and technicians who made this event a success. Thank you one and all.
We have some refreshments arranged, that's it. Yeah. We can have it.
So we just take a photo, please.
So it's in Parkinson from Church Street.
Just take a photo.
You from Bangalore? Church Street, you know that restaurant 13th floor, Ebony, I'm in that building. So in my clinic, it was very fancy and also safe to get the but if I was to do it in a hospital, I would be that it was my favor. Children came from the hospital. Yes. But I asked them to say no.
Sir was really contributed very
Yeah, so we have university time schedule, something like presentation. Because pain medication, we are the pain creators. So we cannot do
Person who takes the photo need not smile.
Smiling at others.
Sarah, come.
Because the part of later it will be part of fellows. Make us to find what the tail was.
Oh, this will be last.
South Zone is part of Anikata. So Sarjapur Road is part of
No, I was private at No, I just like and then I